So thank you, Allison, first and foremost, for sort of teeing me up here with a beautiful introduction of what palliative care is. It is a big theme in my paper that I didn't have adequate time to explain. So I wrote my thesis on surrogate decision-making for patients or people with intellectual disabilities, particularly at the end of life. And thank you to Professor Kuflik for being my thesis advisor on this. Next slide. So I came about this topic as I've been a member of our ethics committee, and I'm the current co-chair of my ethics committee at a rural hospital system in upstate New York. And so clinicians caring for patients with intellectual disability, which I'll shorten to say ID, at the end of life frequently feel as though they're forced to deliver a disproportionate amount of clinically non-beneficial care to patients with ID to satisfy legal protections in place to ensure that that patient population isn't denied access to care or life-saving medical care because of the disability. And so this is a frequent reason why an ethics consult is called. Next slide. Broadly defined, an intellectual disability is present when a person has a reduced ability to understand new or complex information and a reduced ability to cope independently. And this disability begins in childhood and has a lasting impact on development. And so historically, people with intellectual and developmental disabilities have been devalued and treated as less than human. Reporting by Geraldo Rivera in 1972 exposed the horrific treatment of children and adults with intellectual and developmental disability at the Willowbrook State Developmental Center in Staten Island, New York. And so that expose spurned numerous legislative reforms in New York to protect this vulnerable population from further mistreatment and improve their access to healthcare, to education, and to supportive housing. Next slide. So a component of taking care of patients with intellectual disability is this idea of lacking decisional capacity or decision-making capacity. There's lots of different patient populations for whom healthcare making decisions is delegated to somebody other than the patient, him or herself. We know that healthcare decision-making capacity changes.
We're losing you. You're breaking up a little bit.
Yeah, Michelle, you're frozen. Maybe turn your camera off for now. That'll help with the bandwidth.
Status, and it changes across the lifespan, decision making, especially with support. Okay. How about now? Can you hear me?
Yes, we can. Yes.
Okay.
Maybe turn the video off.
Okay.
Better.
All right. Still, many patients with intellectual disability depend entirely on someone else to act as their surrogate decision maker. And so we're left with questions about how to make decisions on behalf of those who have never been able to express their values or their preferences, and who's best able to make those choices and under what criteria. Next slide. So this is a focus on surrogate decision-making at the end of life for patients with ID is essential because about 6.5 million people in the United States have an intellectual disability. And again, many of them depend entirely on other people to meet their daily needs. New York State handles surrogate decision-making for this patient population differently than many.
We're losing you. We can't hear you. Can you hear us?
Any other localities that I've been able to find, and there's a Willowbrook scandal. And so while they cause unintended and unanticipated, oh my gosh, I'm so sorry.
We can hear you now.
How about now?
Yes, we can hear you now.
Okay. With these protections, while these protections are laudable and necessary, they cause unintended and unanticipated harm by advocating for aggressive and burdensome treatment at the end of life and making it very difficult for this patient population to access palliative care and hospice care when appropriate. So there's an ethical tension here between clinicians trying to provide beneficial medical care while avoiding foreseeable harms, and the state's responsibility to protect this vulnerable population from denial of medical care based on a disability. So even when a patient with an intellectual disability has a healthcare agent or a guardian or other surrogate decision maker, there's still this long notification process that happens regarding any decision to withdraw life-sustaining care for this patient population. And so there's often a discordance between clinical caregivers, clinicians, caregivers, and families' perspectives on what best to do versus patient advocacy at the state level. And this is a very common thing that happens. Also, the cadence of clinical care and administrative and bureaucratic processes add to the frustration at the point of care at the bedside. So my paper uses 3 case examples to sort of illustrate some of these common issues. I won't go into that. I won't use the case examples, but you can flip to the next slide. But basically, what I found in doing this research is that there's very, very little qualitative data to guide decision-making for patients with ID at the end of life. In one case example that I used, it would seem that the language of the law really supported a transition from curative care to comfort care, but the interpretation of that law through members of the surrogate decision-making committee that participated in the decision-making for this patient, in which he received a tracheostomy, really precluded him from ever returning to a familiar care environment where he could have received supportive care. This is a particular patient who would have been an ideal candidate for hospice services, but instead he died in the hospital after a 2-month hospitalization. Had he survived longer, he would have been in the acute care facility even longer, because transfer out of our facility would have been stymied by the fact that we don't have any locations near us that are able to accommodate patients with tracheostomies who are ventilated. Next slide. So where do we go from here? Obviously, there's a lot of research that needs to be done. We just don't know enough about the experiences and preferences of people with intellectual abilities at the end of life in order to make treatment choices on their behalf at this critically important juncture. We need an improved understanding of the needs of this patient population that will hopefully inform resources necessary to improve care, and propose reforms for a more reasoned approach for surrogate decision-making at the end of life. New York State has to sort of pony up some more resources in a lot of ways, things like training for nurses and respiratory staff to provide care in the home itself or in their residential facility, and clinicians and then there's the shortage of nursing homes and assisted living facilities in New York that continues to be a catastrophic issue for many, many people across the care continuum. And we also need resources to conduct quality improvement, debriefing, and tracking of how these decisions are made for this particular patient population so that we can do better. There's just not a lot of information or systems out there that are looking at this problem or publishing on this. And finally, there are some complicated reforms, but I think there's some low-hanging fruit in terms of, empowering patients with ID who are able to select a healthcare agent to avoid this really bureaucratic double check, since we have a process already in place that permits patients with intellectual disability to select a healthcare agent, but we still impose all these extra checks on them, even if we have a system to say that they are able to choose their decision maker. And so the autonomy of those patients is limited by the requirement to notify for withdrawal of care. Next slide, or final slide, I should say. So my paper advocates for assessing how protections have helped improve the lives of patients with intellectual disability, and trying to determine how those protections can be enhanced through inquiry, more dedicated resources, considered reforms, and we could really make New York State a vanguard of how best to care for patients with intellectual disability at the end of their lives, and sort of repeating time and time again these predictable but unintentional harms on a vulnerable population that the state is actually obligated to protect. That's it. Thank you so much for bearing with my technical issues.
No, that's great. Thank you so much. And you've really identified sort of a niche, sort of a gap in knowledge, which is really important. So that's terrific.